Anyway, I'm going to talk to you today about documentation, not from the trauma nurse's perspective, although we still can't let go of that, but also from the registrar's perspective. You all know who I am. I've been a nurse a lot of years, 35 years, and around 20 was in that unit, and then 10 years in trauma before that. But now I'm over in the office there, and a gentler world, having water at my station, going to the bathroom without having to announce it. all the little things that you miss when you're in there. At the conclusion of my talk, I hope you have a better understanding of the uses of the recess flow sheet, realize the value of the recess nurse's documentation, it really is, and have clarity on some of the data elements that we're collecting from the recess flow sheet. Who looks at the recess flow sheet? A lot of people. Trauma administration, trauma registrars, burn staff registrars, case managers, research staff, insurance companies, hospital coders, and lawyers. And you know that's part of the medical record, and a deposition can come up years after an event. And this is where it's really important to have all the documentation there, because you're not going to remember things. Many, many years back, I gave a deposition, and it was like 3 years after the event, but I was one of those wordy people, and every question they asked me, and it was like an all-day event, I was able to open and say, not a personal recollection, but according to my documentation, and it covered everything, and I was very thankful to be a wordy person. Anyway, what do we review for? We're looking for performance improvement opportunities, quality assurance, trends, deviation from protocols and data elements, and some of the things that you were addressing pre-hospital are things that when we scan them, we're looking for right away, and we're trying to address it very timely so that it's still fresh in people's mind. One of the things is unannounced patients. Some of the other things you brought up with, there are times where the C-spine should be definitely there. The patient complained of pain, and there's no documentation as to why they didn't do it. But then there's a lot of times now, as I mentioned earlier, where they're saying that it's acceptable. It's acceptable. So if they have said that the patient denied all this pain, they have refused the spine precautions, that we're not going to ding them. Because if it is one that should definitely be there, or an unannounced patient, they do get the county, they do get informed, educated, QA'd, just as other areas would be, whether it's hospital, pre-hospital, the other hospital. So we are looking at all that. We do try to get the flow sheets the next day, again, to address it in a timely manner, any of the things that might be missing or things that need to be looked into. The weekend, it goes a little longer, so it's a couple days after the event, but we still try to be timely on that. We look for trends, and if you've been around a while, you might remember when the implementation of all the gear for any kind of central line insertion, because there had been a spike in that was captured, and they addressed that. And I haven't seen a central line infection for years, you know, so it worked, as much as people didn't like it, but things like that. Who else is going to be looking at this recess flow sheet? ACS has come in to evaluate our trauma unit and decide whether we're going to remain a level 1 trauma center for another 3 years, or if we're going to have to change some things. They're coming this March 15th. March in 2015. They're looking, 2 trauma surgeons will be coming from the American College of Surgeons. They also bring nursing staff and specific people. They're going to review the medical records. They ask for specific things, and they're looking at patients from right now. So, and all the documenting you're doing now could definitely be ones that are going to get reviewed. And they review them from the pre-hospital, the review, the recess flow sheet, and the whole length of stay. What's the NTDB registry? That's where we're putting data, and it's the National Trauma Database Registry. The database contains information of injuries from patients presenting to local hospitals, whether they're a trauma unit or not. We try to capture it. And across the nation, we share the information. They'll pick up trends. This was started, by the way, by the automobile industry many years back. I'm going to say it was definitely more than 3. It was the Automobile Club of America that started it, because they were looking at things about motor vehicle crashes and injuries associated with that. And over the years, a lot of changes have come out from this kind of data, what kind of injuries with what kind of vehicles, and as was mentioned earlier with the crash zone and how the vehicles go, the redesign of the seatbelt and shoulder belt, airbags are under fire again now. But things like that, this data is really good. And it's also been collected, we don't do the pediatrics much here, but a lot of changes in their clothing because it's also burn. But we don't do the burns specifically. There's a burn registrar, by the way. But things that have changed in the children's equipment and clothing as a result of this. It's over 30 years old. We've been participating for a long time. I think from the very beginning, Peg was the one who submitted the data initially. Those of you who have been around and remember her. She's the guru of this all. Quality improvement opportunities again, injury prevention, clinical research, and policy development, and much more comes out of this data. This is kind of an example. We're looking at the paperwork and putting it into a specific program, and it gets submitted quarterly to the TQIP, which is a part of the American College of Surgeons, and they review it and they'll show trends. For example, this last one, much to our dismay, was looking at pneumonia and head injuries. It didn't go the way we wanted. Who else reviews this data? The Trauma Division, the County Emergency Medical System, the National Trauma Data Bank, as I mentioned, Trauma Quality Improvement Program, and the State of California. And again, it's a part of all our regulations. They're reviewing this. The registry data collects elements from pre-hospital, and that includes what happened, when, where, time of incident, the treatment that was rendered at that time to the patient, protective devices used, and if it's a motor vehicle crash, position in the vehicle, whether it was a driver, a passenger, front seat, back seat, right, left. It asks all those things when we're collecting the data. Additionally, when he was mentioning the extrication, we do keep track of that. The longer the extrication, the ratio of outcome is lowered as far as being as good, you know. The other thing is they're using more tourniquets now, and I wanted to bring that up. This came out of the current wars going on that they're using tourniquets to help control bleeding again. So we may be seeing that again, keeping that data from the pre-hospital, and it's important to keep track of the length of time a tourniquet's on for bleeding purposes. Just a little side note there. Then the trauma patients that are coming from other hospitals, you know, we get all of these Scripps Chula Vista ones, El Centro. We're collecting their data too, which includes the times they arrive there, the times of injury, the procedures done there, the images done, and how they're transported and any intra-transport events. The elements are collected from the recess flow sheet. Now here's where we like it, here, for the dates and times of the patient arrival, the physician's arrival, when they're called, when they arrive, the different consults, the trauma team, of course, the vital signs, the GCS, fluids, procedures done in the recess room, injuries noted, and that, I pay a lot of attention to the nurse's documentation on that, figures, because they're a lot more thorough usually than the physician's one, even though they have one too. The people present for that recess and the disposition of the patient and any complications that occurred during that time. Here's an example of some problems with the documentation. This is dates and times on the accuracy. There's a lot of conflicting things here. Let's see if I got that working. So it takes us a while to figure out who's right. Often the physician's trauma attending worksheet will differ on days and times than the nursing one. But you'll see here, they have the patient arrival at 7:02. They have the page going out for the doctors to come at 7:52. And the team arriving at 7:52, we know that they didn't wait 50 minutes to call anyone. So it's really important what we're meaning on this. If this patient comes up from the ED has their own arrival time. This is meant to be the date and time that patient enters your recess room. This is meant to be, the time called is the time that the page goes out to the trauma team. And if it's one of the other specialties, the same thing, the time they are called. And then the other time arrived, that's the time the first trauma doctor arrives. We get the trauma attending's arrival time from their flow sheet, by the way. And again, here's another example of some conflicting times. You'll notice the first set of vital signs are done at 15:47, but the page went out at 16:43, maybe not. The doctor arrived at 16:43, but it also shows the patient arrival time at 16:41, so the vitals were done you know, in the recess room before they got here. So we don't know what to make of these. So it's difficult. So this is your charting and your legal document, and if they can disregard something like that, they may try to dispute some of the other data in the future if you're ever under fire with the attorneys. And again, there's the trauma attending flow sheet. Notice they have a lot less to document, but we get their arrival time, and sometimes they address they should be addressing always the consults on here if they don't on the recess sheet. So we look through all of that to try and figure out if the consults were in an ordered and appropriate time frame. And a lot of things that you may not realize up there, there's definitely set rules on how long they're allowed to be in the recess room in the recess phase, how long before you get a neuro consult and they show up in that recess room. There's time things that we write them up then if it's not falling in this. An open fracture has to be to the OR within 6 hours, a head injury within 2 hours, you know, certain things like that.
So Babette, 2 things.
Yes.
Does the attending write the actual time they came?
Yes. The trauma attending or trauma fellow, that's what they're supposed to be writing in.
And then
This is the supposed to be. Over here. Now, Jeannie Lee is excellent at filling hers out, as you might imagine. Leslie Kobayashi is excellent at hers, too. There's some good documenting physicians as well, and some that aren't. And I don't have to tell you who they are.
There's a discrepancy and
The
attending was never there.
Then that's something we investigate, too. That is a problem.
Don't write it down.
No, we enter it in, and that gets investigated. It gets followed up on the next day.
And then how about the consults? They don't always tell us that they're calling.
I know, and that's a big issue that's trying to be addressed, and it should be on them to let you know. Now, there are times they write on their own flow sheet a time that they have as that they called back. So, yes, that's an ongoing problem that I haven't solved yet. No one's solved yet, and it's out of my hands. It's still between Dr. Coimbra, them, and deciding as far as that documentation. And you probably are aware, you know, they want the nurses to be responsible, but that's unrealistic because you could be transporting at the time they're calling ortho or neuro. And so exactly, I know, they're bad about it.
And they all go in the corner there and they talk among themselves, and then you don't know what they're.
And you know what? It's been like that a long time. It's still going on. We're actually discussing this on a regular basis all the time, and because of all the principles involved, it's not solved yet. And I don't have an answer for you. I know the problem. I'm aware of the problem you're talking about, as is our whole department.
They have to respond within a half an hour. They don't have to be there. Is that what you're saying? The consults.
If it's reasonable, if you have somebody, there's discussion on that too. They have to, if you have a patient that needs to get to the OR pretty quick and it's a neurosurgeon, they're taking their time, there's a problem. You know, sometimes they'll call back and say, or ortho, I'm doing a procedure here, can it wait? And they'll say, yeah, go ahead. You know, if it's a somewhat stable patient, it's something that they can just come and consult on, but not have to take action right away.
Do the attendees have to put the time they call consults on their sheet?
Yes. Do they do it?
Because they're not there.
Do they get, this is something, you know, at times we're really trying to capture data, and this is a battle going on behind the scenes right now. And I'll leave it at that. It is a problem. There's certain things that have gone on for a long time here, and I'm not able to, Lori's here somewhere. She and I will stick up for it and say, that's not realistic, that's not. And Pat too. Pat used to work in the trauma bay too. But we haven't solved anything we don't have the power that Dr. Coimbra does or other authority does to resolve it. So we're trying. We are working on their documentation right now. We are presenting them with copies and copies of their misdocumentation. So this is something that's being addressed very wholeheartedly right now. All right, and so when I get more information, or hopefully you'll hear more or start seeing better results at some point. I'm going to go ahead and move on to another element for the recess flow sheet, and this is the Glasgow Coma Scale. A few things. If you have a GCS that's less than 15 on arrival, or you have a positive LOC or some kind of definite head injury, there should definitely be more than one GCS, especially there's times where patients have spent several hours in the recess room and there's only one documented. And we know that you're talking to this patient, you know what their GCS is. Just make sure you write it down, because otherwise it looks like when it comes to it that there's gaps of 4 hours. No one's done a GCS on a patient who was a 14 when they came in, or a 13. And, you know, so it's like, aren't they observing? And you know the standard when we put somebody on the IMU, they're going to get them serial GCS scores documented. So we should be doing it too. You know you're doing it because you're interacting constantly with that patient. Another thing is just a reminder that a spinal cord injured patient doesn't necessarily have a motor response of 1, no response, because they can respond with their mouth, their face, their eyes. They can be a 6. So it doesn't mean they're not moving their extremities. It means responding with a motor response to your command. And the third thing is the lowest GCS is actually a 3. If a patient comes in and they're coding, and you're continuing that, they're not a 0, they're not a blank, it's a 3, because if you think of what it is, eyes opening, no, that's a 1. Verbal, none, 1. And motor, none, that's a 1, so that's a 3.
Some people put 0?
Yeah, or leave it blank, you know, because they're coding, but that's what they are. Fluids, let's talk about these. We want to really emphasize blood products being entered on the, did I turn that off? On the fluid column, because this is being kept track of the first time they're getting blood, and this is something that is going to the national database, but also locally and within the hospital, that somebody who's bleeding is getting blood in a timely manner. So be sure to enter on not just blood, but on all fluids, the time that it goes up, how much, and the type of fluid it is, whether it's saline, 3%, LR, whatever it is, or the FFP. You know, a lot of times when people come in with their INR greater than 1 and they're on Coumadin or something, they have a head bleed, they're going to be giving them FFP pretty quickly. We're also now collecting information on Kcentra and some of those reversal agents too. The other thing, if no fluids are given, because sometimes on the elderly, and of course our trauma population is a lot of falls, the demographic bulge is getting up there with us elderly, because I fall into that now. They're holding fluids because, you know, if their vital signs are stable, because they don't want to overload their lungs or their heart. So keep that in mind, write that down, no fluids per doctor such and such due to CHF or whatever it is. Or a renal failure patient is another example. Some fast facts. First of all, what's a fast? It's focused assessment with sonography and trauma, and we're specifically looking at the abdomen here in the trauma setting. We're looking for free fluid, and that's it. We're not looking for their whole history on all the organs. So a positive on a fast is free fluid is found, which can mean blood or something wrong in there. A negative is no free fluid found. If you have a chronic illness like, say, cirrhosis, they say, oh, he's cirrhotic, or he has a cyst on his kidney, things like that. They're not looking for the history at that time. They're looking for trauma injury. So it's either yes, free fluid, or no free fluid. And it's found on the flow sheets as ultrasound of abdomen. That's the same thing as the fast, so you don't have to rewrite the fast. Now when you do have to rewrite something is when it's an ultrasound of the chest, for example. They look at the heart a lot of times, or, you know, pericardial. Or if they used to do necks at times. I don't know if they're doing them that often. I don't see them on the flow sheets much, but things like that, yes, do write it in. But what we're looking at and what the flow sheet, when they say ultrasound of the abdomen, they're meaning the fast, so you don't have to write it twice. Yes?
So we were told the reason why we put ultrasound of the abdomen is because we've always had the sonographer come in and do a full abdominal ultrasound, including looking at the kidneys and stuff.
Yes.
When Dr. Doucette comes in, he does not do an ultrasound of the abdomen, he does a fast.
Yes.
So
they are a different animal in that the sense of the full thing. A lot of times, though, even I believe that even when the ultrasound tech comes in, what gets put into the computer is still being the fast, no free fluid.
okay.
Now, there's a point, we definitely want to know comorbidities and everything on a patient, but when we're looking at the trauma resus phase, they're wanting to know free fluid or trauma or no trauma. And so, that's it. And that goes for other x-ray exams, head injuries and things like that. They're not necessarily looking at that time for the atrophy of a brain because of drugs or whatever, or they're looking for some kind of traumatic injury to that brain in that head. So other radiographic studies, CTs and all, they're looking yes or no, trauma, positive or negative, trauma injury or not. Because a lot of the patients, you'll be documenting all day all their history and physical of comorbidities on them, and they're looking at all this. That'll come later, that's up to the physician. Just, we're looking yes or no for traumatic injuries, okay? Then another important thing is the patient disposition, completing all areas of that. This is your transfer information, and that is really saying, I'm handing this patient in this condition to the next level, whether it's IMU or the ICU nurse, or sometimes it's even change of shift. So make sure that you have all those areas filled out. You're covering yourself on that. And here's the checklist. It's transfer where they're going to, and that should include whether they're a boarder there. I know sometimes the trauma patients that are ICU patients have to go to the PACU as a ICU boarder, sometimes even IMU boarder. A lot of times you'll get IMU patients in the ICU. So be sure you're marking that down to the level of care they actually are. The time of the transfer, make sure that's accurate because that's saying this is when I'm handing them over. Equipment needed for that transport. Spine status, has their C-spine been cleared, or are they still in C-spine, TNLs, whether they're clear or not. The pre-hospital IV site, there's a time limit on that, so it's important to have it there so that the nurse following the trauma nurse will know when it has to get pulled out and get a new one in. The physical, I can't hear you.
Are the pre-hospital IVs, are they only the ones that are done in the rig or in the field by the paramedics, or have they got an IV that's been in scriptural vista or something like that? Is that?
I think, okay, I'm not 100% on this. I can find out and give you a more definitive answer, but I believe through history they're still considering that pre-hospital and want them changed. Within 24 hours, I believe, is the set time. But I will follow up if that's different and get back to you, okay? Alrighty, and then the physical status, anything specifically going on, like they've been hypotensive, or, and their emotional status. Well, that's a whole nother chapter anyway. Their current pain scale at the time you're transporting them. Their GCS at the time of transport, even if they've been all over the place there, what you're turning that patient over to the next nurse as. Skin breakdown, sometimes we've gotten for patients that have been on a backboard for hours and they've already got something going on, the cubes and all. Cover yourself, document it there. Family contact information, whether they've been contacted and information. This is all like helps for the next person too. And your signature, you're the one signing off that. Yeah, Cindy.
There's some discussions we've been doing this, looking at our flow sheets on info given to patient in the resus room.
Yeah.
I did not give them that info. I've always marked no.
That's fine. At least you've said it's not been done. I know it addresses here like doable power of attorney and all that. Chances are we're not addressing that. It's not a ding if you don't do that. So just say no. Yeah. I mean, so who has time to do all that niceties?
Well, we know admissions, it's their job to give it to
Yeah.
the admissions, so that's why.
So it's nice if, you don't have to be redundant and you can say no. It's okay. And the same thing for change of shift. You're handing the patient from one nurse to another. You want to make sure that there's a continuing of this care, that what you've handed off and is continuing on, and that it's documented. So review the flow sheet between the two RNs. The offgoing RN should definitely complete the areas of their notes and everything, and sign off the flow sheet there. Then and they should ensure no blanks or gaps. Both nurses should do that. There shouldn't be any blanks, saving spaces, or whatever. You have to move on. Oncoming RN is then responsible to complete the resus story. The whole thing, continue the story so there's no break. That somebody can read it and it went from Erna to Jeannie and it's all there. And then they will make sure this transfer information is complete when they pass the patient on to the next person and sign the flow sheet again. Take credit for what you're doing too, all those procedures. Revisions. Okay, sometimes people forget something or they realize they charted something wrong, and it's okay. Everybody does that. If the flow sheet's already out of your hands, you can still correct it. You can get a blank flow sheet. You write the patient's information on it. You write at the top addendum or revision, and you write just what you need to change and send it off to medical records. It gets scanned in, and we do see these where in Epic that they've scanned the the revised one and the original, and so the information's there. And you can say late entry or whatever. So it's okay to do that. At times it happens, you're really busy. And some great examples of charting are, you can look at some of the experienced RNs and also ask them for advice too if you want to, but look at their examples. And a couple of examples are Jeannie and Sandy, who've been here a long time and they never leave any blanks, it seems. I mean, I know I didn't do as good either. So they're good examples. So I'm going to go over a couple of really good ones here. Let's look at patient A. I've handed you first. On page 1, I want you to see that they've completed the times that the patient arrived, date and time, a bit of the pre-hospital information, the time the doctors were paged when they arrived. Everything's filled in. You'll notice down at the ABG at the bottom, they wrote why they don't have the ABG. It was clotted. So it's addressed, that's fine. And then on page 2 of this same patient, you'll see that the fluids are listed, what they are, how much was put up, the vital signs are complete. They actually did serial GCS scores. It's perfect because it was every 15 minutes pretty much. And then on the section 3, you'll notice that the whole transfer information is complete. It's all there. I did white out the name of the family and all, but it was there really. And their notes. So you read this and you have all your questions answered, and the person who's charting that is, if they ever go to court, they've got their answers too for that phase of it. Let's look at B. I'm trying to do these kind of quick, but this patient, again, look at the page 1 of it. They have a really good documentation of the pre-hospital. The arrival information's there, date, time. Whether they had collars on or not, they mentioned that they did have a PIV once. There's the time that the team was paged, the time the first one arrived. They also, now here's a little different on this, they did mention the time that neurosurge was paged, so somehow they had that. Yeah, it doesn't have the time that they actually arrived, but on page 3, you notice in their note that they said, Dr. Santiago from neurosurge is going to see the patient on arrival to the SICU, so it is addressed. Then another thing they did have on here that was a little on page 1, you'll notice they did the fast abdominal ultrasound thing differently. You don't have to do that. Save some time when you can because you have so much you do have to write. Okay, on the fluids, again, they have the type of fluid and the amount. They charted the LOC twice, or the GCS, and this patient had a LOC, I believe, twice. They covered that they changed the Philly collar. They wrote in some things that were going on. The figures of the people have the injuries well written all over it. It's great. The transfer information, and this is a really good showing of transferring from one nurse to another in the recess room, and they did a really good job on this. They had all the information complete. They both signed the transfer information. The nurse from the first shift completed her notes and signed it off. They gave report to the second one, and it just picks up where you left off. So that was a really smooth transition. Those are 2 really good examples, I thought, and that's what I pulled up from yesterday, I think, reviewing them. The other thing, though, to tell you, for all the pink copies you get and say, what was this? You guys do over 250 recesses a month on average, and the fact that you may get a handful here and there, that's pretty good. So in all, it's really good charting. So I'm going to pass these because they aren't as easy to look at as the ones we handed you. So I'm going to throw little questions at you here. What would you write? You have a 22-year-old female, restrained driver, and she arrives to the trauma resus bay at 18:45 without any pre-hospital call to the trauma bay. So under trauma team for time called, you write A, no call, B, unannounced, or C, 18:45, because that's the time you put out the trauma page.
B.
Yay, okay. Pens. For all the ones that, yeah. So, let's see. Why, yes, that's right. As you know. Okay, another one. So, same patient actually. A 22-year-old female restrained driver arrives in the trauma recess room. Her FAST shows a cyst, a renal cyst, but she has no free fluid. What would you document for her ultrasound? Yeah. Okay, no, I don't want to hurt anyone. Or myself. All right. Yes, you're right. And the third one. What would you write? The trauma team is still taking care of the 22-year-old female from the motor vehicle crash when the trauma phone rings again. You receive report on a 33-year-old male coming in from jail, status post assault. What should you do and document for the trauma team, time called and time arrived? Trauma team is here, so don't page. Document trauma team already here for time called and time arrived. B, put out the trauma page and write that time for the time called and document trauma team here for time arrived. Or C, tell the MICN you don't have the staff to take another patient. Yes! You guys are right. So you know what to do now, right? Okay, all funny until somebody gets another hotel. Yeah, share. Let's see how far back I can get. All right, I can't get that. So you can divide all right. Almost succeeding. Okay, so in review, your charting should tell the full story. You should be able to read your notes and know what happened. You should have no blanks and have no conflicting data. Take credit for all the work you do. All those procedures, all those vital signs, all those GCSs, all the fluids you're giving, take credit for it. You do a wonderful job in the most difficult situations, and all of us registrars really appreciate it because they're usually really very informative sheets of paper that gets, it's like the skeleton of beginning for the whole stay in the hospital, that recess flow sheet. So thank you very much. Any questions? My hero, right? No. All right.